I'm one of the founding directors of ShiftTB alongside with Amrita Daftari, who's also here, and Jeremiah. I think I also saw you log in. Welcome all. So our theme today is planetary health and tuberculosis. And we thought this is an important theme to cover because we live in a world where we have overlapping and interconnected crises. Think of climate change, pollution, biodiversity loss, AMR, rising inequalities, and the resurgence of diseases such as TB. And they just underscore that we really have to attend to these fundamental interdependencies between human health and the planet and our ecosystem integrity. So in this webinar, we want to explore how social science contributions can help understand the impacts of planetary health on TB and how we can maybe co-develop solutions. ShiftTB, for those of you who are not yet familiar with it, is a global network connecting social science scholars and community members world over to stimulate thinking around the social and socio-medical dimensions of TB. The center is funded by the Social Sciences and Humanities Research Council of Canada, and although we function as a borderless and virtual network, the infrastructure is hosted at the Dadale Institute of Global Health Research at York University, in partnership with the Vrije University Amsterdam in the Netherlands and the Human Sciences Research Council in South Africa. And as is customary for all institutions in Canada, we will take a moment and read a land acknowledgement specific to the university, to York University, and encourage you to think about acknowledging the land you may be upon as well. Hannah, can I ask you to read this?
So First Nations people have lived on this part of Turtle Island for millennia, stewarding the land, the water, and all that contributes to life in this region. Today, the culture and presence of First Nation, Inuit, and Métis peoples enrich the lands and people of this territory. More than 2 centuries ago, the Mississauga people welcomed settlers to this territory, providing sustenance and engaging in trade and commerce. Between 1781 and 1820, 8 treaties were signed with the Mississaugas of the Credit First Nation, who opened their territory to settlement. Today, York University's Keele campus is located on Toronto Purchase Treaty Number 13 lands and is situated on the traditional territory of the Huron-Wendat and Haudenosaunee. Treaty history is foundational, and it is our collective responsibility to honor the land as we honor and respect those who have gone before us, those who are here, and those who have yet to come. We are grateful for the opportunity to be learning, working, and thriving on this land, and we commit to learn the truth and be active in the process of reconciliation.
Thank you, Hannah. I now get the pleasure to invite our speakers. So how we will go about this webinar is we have 3 speakers who will speak for about 8 to 10 minutes, and then we have a few moments for Q&A, and then we hopefully have some time left at the end for general questions and answers. So please, if you have questions throughout the talks, type them in the chat or memorize them. Our first speaker is Carol Devine. She's a social scientist, researcher, and writer. She's currently Chief Operating Officer at the SeeChange initiative, which is a social purpose organization in Canada that supports communities in their health responses their way. And she's also, among others, a community scholar at York University. And in her work, she explores the intersection of tuberculosis, climate change, and One Health from a community response perspective. And Carol will talk to us about the mental health impacts of TB and planetary health in Inuit communities. The floor is all yours, Carol.
Thank you so much, Nora. I'm just going to set up my PowerPoint, but in the meantime, say, I really appreciate being here with you and Karuna and Ellen, Hannah, and Amrita, and all of you who've joined, looks like from around the world, which is really exciting. And I will just get going. Sorry. All right. I would like to say that I love this topic, and I think planetary health is something that Inuit and Indigenous peoples have known before it was called planetary health, and it's a really wonderful topic on World TB Day. And I want to acknowledge I'm not speaking on behalf of Inuit. I'm very honored to have worked with Inuit colleagues, Inuit leaders, Inuit youth, and that informs my short, discussion or some things I'm sharing today, but any errors are mine alone. And I really wish that my colleagues, my Inuit colleagues, could have presented today, but here I am. So I'll just jump in and to say that, you know, community first, that's really the idea of SeeChange initiative. And it was founded by my colleague and friend, Rachel Cadell-Monroe, who heard about the TB epidemic in Canada. We'd been working on TB in South Africa and Central Asia, India, that Karuna will speak about. But what about Canada? And it was Stephen Lewis, who was former UN AIDS envoy at the time, who rang the bell. And that really got SeeChange going, the idea that there's these humanitarian issues, but communities know their solutions. Again, I want to acknowledge my colleagues in Nunavut and elsewhere, and my SeeChange colleagues. And fast facts, I won't spend long on this, but I think it's important. I should have changed the map to include the whole Inuit Nunangat, the homeland of Inuit. And there's about 39,000 people. It's a small population, but about 90% is Inuit in Nunavut. There's 25 communities. You have to fly in. You can imagine how that impacts TB care. And if you think about TB in other parts of the world, there's distinctions and similarities. Nunavut was a territory created, and it's a step towards self-determination with a public government. And the colonial policies, I won't spend too long right now, but I think it's so important to say that when we talk about TB in Nunavut and Nunavik, the big crisis right now, we have to talk about colonial policies, including forced non-consensual TB evacuation to the south in the 40s to the 60s, when a third of Inuit had TB. And I mean, that came from outside, that came from whalers and visitors. And then the other interrelated harms of the colonial policy. I mean, the idea to send people for treatment is a good idea, but along the way, it was just a failure in so many aspects, apart from people getting their health back. Some didn't come home. And I think a really foundational thing to share that I've had the honor to learn and have a lot more to learn and unlearn is about the land being so important. So we're talking about planetary health today and TB, and you know what we know about TB: food security, clean air, good ventilation that Ellen will talk about. All those things are impacted in Nunavut already and now exacerbated by the climate crisis and planetary health concerns. So this stat is a little bit old, it goes up and down, but the major point to make is that it is disproportionate in Canada, the TB incidence. It's just unacceptable today. And, you know, there are colonial roots, and that's about social determinants of health that we're discussing today, all of us. And right now in Nunavut, things are improving, but it's not resolved. And there's been some credit to Inuit leading the response alongside, you know, medical colleagues. But this 2-year-long outbreak has been declared over, but there's still active outbreaks. It's not resolved. There's still much to do, despite all the amazing efforts. In Nunavik, it's a big crisis. You may have heard that the Canadian Red Cross was called in. I mean, you know, as a humanitarian and a health person, I don't lament that we have to call and ask for help, but it's a real sign in Canada. Why wasn't it not more in the news? The fact that it's just like a world crisis, like at the highest rate in the world probably right now, or back in at the beginning of the year. So the numbers are going down. But I think that as the head of the part of a program manager about tuberculosis said, we need housing and infrastructure. So the social determinants of health really come into play. And, oh, my slides. Here we go. And I think Natasha McDonald, who's a professor, an Inuk professor at McGill, you know, is talking about just this unacceptable thing happening, this unacceptable crisis happening in Canada, and the mistrust, and we have to talk about history, the mistrust and the stigma around TB related to colonization. The good news is there's the Canadian government and ITK, which is the national representatives of the Inuit, have this task force, have really thought about how we're going to eliminate TB, have set a goal of ending TB by 2030, but the goal of reducing the rate by 50% by last year was not met. And we're seeing a retreat from funding. It's a real problem, when the solutions are at hand. And I really appreciate that empowering and mobilizing communities is strong in there, and accountability, reducing poverty. The topic today, health, mental health, it's also interrelated. And we have to say that I'm not a health person or a mental health person, but we know historical trauma drives stigma and fear. We know that the TB sanatorium history must be spoken about, and it's almost its own social determinant of health. TB and mental health go together, like in other parts of the world as well, and TB and HIV. Fortunately, HIV is not a big problem in Nunavut, but we know that globally depression is a factor, and we know in Nunavut this loss of ice and land, disrupted hunting, food insecurity, less country food, less intergenerational outings on the land, really, which are protective mental health factors, are having mental health impacts. And then on top of it, you have climate change. I'd like to really shout out a colleague, Sarah Fairwati, who's the first mental health epidemiologist in Nunavut, and some good initiatives, Embrace Life Council, Ilisatsavic. There is work on mental health related to TB, related to other issues, and the highest suicide rate in the world, particularly amongst young men, but it's not enough. And then you have the climate crisis and more exposure, more mental distress, and then the wildfires. So we're talking about these compounding crises. I want to give a couple examples and then wrap up, but we want to listen to Inuit about we started by working on, supporting TB, awareness raising in Inuktitut, and then this wonderful woman who's now 85 and our colleague's mother, Ida Adaguyak, said, you know what, we need to go back and visit these sanatorium where we were sent in the 50s. That'll help with healing. That will help fight TB. And so, they got treatment, but they also lost language, lost connection to land, lost culture, had a difficult time on return, and some didn't return home. So we said, okay, let's go. And we partnered with NTI and Ilisatsavic for the first visit in 2023. We held healing circles. The Hamilton community was very welcoming. My colleague Hannah is here with me. It was an incredibly special experience and an honor. And our Inuit colleagues told us that they did feel some healing. Ida said when she said a prayer, not only for themselves and other patients, but to the nurses, the Canadian nurses who tried to help, or the Southern Canadian nurses. And Naomi Taddy, our intercultural health lead at SeeChange, and really who worked so hard to bring these elders down south and youth, said that bringing youth was important, not only for healing and the mental health aspects, but also for reducing TB in Nunavut and getting to this goal to eliminate TB. And someone who joined us on the 2023 journey, Iola, who's also a rapper and a really wonderful young man, said it's the first time he'd heard about the TB epidemic. So that's why we need to talk about TB and what happened to the elders. And it also is healing for the elders, but also the community and the youth. And I'm going to end with just this scoping review. And I'm really delighted that Hannah Lamgary, who's here on the call, and Dr. Daftari and SeeChange, we're looking at this intersection of TB, climate change, and One Health from a community response perspective. We're just writing up our paper, but in our discussions about TB, working in Nunavut, working in the Arctic, you can't not think about TB and climate change, planetary health, and all these interrelations and exacerbations. And actually, Dr. Daftari presented this at the World Lung Conference, some early findings. I'm not going to read it, but just to say that, we know quite a bit we know a lot about TB. We know a lot about how to treat it. Dr. Karuna will also speak about the social and the social perspective. We have the medical tools. They can always be improved, but we have to talk about, and we found a lack of literature for some regions, in particular about Indigenous peoples and about colonial history is very important. And some parting thoughts. I mean, the book, I was really happy to see John Green's book, Everything is TB, because young people in Toronto were talking about TB more. And I think naming colonial TB history is very important for elimination. Funding, I mentioned that there was this 2030 goal. It barely got refunded. Meanwhile, Canada's focusing on securitization and mineral development and mineral exploitation. So we need adequate long-term Inuit funding, and the mental health aspect is so incredibly important. And it is related to climate change and planetary health. And I think everything comes back to whether it's in Nunavut, in India, in any other parts where TB is really still too much of a problem. Equity and justice have to be centered, and climate action. We can do it. I love the tone of this webinar we're doing together. So thank you very much.
Thank you so much, Carol. This was wonderful and right on time. Well done. I open the floor now for some minutes Q&A. Who would like to respond or react? I was just struck, Carol, maybe I'll start before the others can come up with some questions. I was struck by a few things that you said and, putting on the social science hat. So if land is key, and we'll hear later from Ellen, air is key, how can these are not necessarily often, oh no, let's put the question differently. How can we as social scientists, contribute to studying these more? To giving them land, air, more space in our sort of social science analysis. We might not be, geographers who might do that more regularly, but how can we include these sort of more material aspects in our analysis? I think that is maybe for me a key interesting insight of what you said, and then also this intergenerational perspective, right? That you so easily are able to capture as a historian, as a social scientist, through conversations, through surveys, but that is much harder to bring through in sort of public health approaches. And I really liked your framing of history as a social determinants of health. And I wonder if you've had any experience in the more programmatic world that you've been in, if this has any traction as a strategy to frame it that way.
Thank you, Nora. Those are really great questions. And so really briefly on the kind of first aspect about the land and the air, I mean, I'm seeing something positive. It's partly how, it's part of the problem of how we've separated medical from social. We're getting better at that. The webinar is testament to it. But, I was at the COP meeting in Egypt, and there's Canada's pavilion, there's Egypt's pavilion, there's Botswana's pavilion, and there's a pavilion for oceans. And I thought that's the thinking we need to think. They have voices, they can make noises, but how are we learning from Indigenous peoples or people who live so close to and value nature more than the kind of separate way we think of ourselves as not nature? I think that's really important for the social sciences and for fighting TB is including these perspectives and not seeing it as we just need to keep bringing them together. And I think for me, because this is new, I don't know the roadmap, I'm still articulating, it's talking about it. And it's the same with people say, hey, Carol, you're working on TB. What are you doing? And I'm like, I was just in Hamilton, like an hour away at a sanatorium, and we went to the zoo because the elders wanted to go to the zoo. And people are like, hang on, how does this fight TB? So I think we're still developing how to frame it, on the ground pieces are ahead of the game. And I think that, there's some Canadian funding went to finding graves of TB sanatorium survivors, the Nunavut initiative. It's amazing. It's fantastic. Inuit just funded themselves when the Canadian government was belated, just funded kind of food baskets to people with TB. The more we talk about these examples of communities leading, and the more we talk about how climate change and TB are all interconnected to history and the land. I don't know, Nora. My answer is basically, we'll figure it out, but we just got to keep talking about it and sharing together.
Who else would like to ask a question? We have one more minute before we go to the next speaker.
I would love to ask the question, Carol. Beautiful talk as always, but just coming back to the intergenerational piece, what have you seen? What do you see on the ground in terms of the connections and the approach to which people talk about the land from this generation?
Yeah.
That I would argue is a bit more urban, I guess.
Yeah.
And has a different history. They're entering the Canadian space with the TRC, the Truth and Reconciliation Commission at play, as poorly played as it is, compared to the
Okay. Thank you. That's a great question too. And I've really appreciated our collaboration over the years. I mean, the best thing is example stories. Like we were in Ottawa at this ArcticNet conference, which with some youth who'd been on the TB trip to Hamilton. We're walking down the street. This guy's on TikTok and Spotify, Iola, who I showed his picture earlier. And he's talking about climate change. He's saying, he lives in Kinnight, where there's the big Inuit art studio, but also the Kinnight Sea Ice Glossary, where elders are talking about the changes in the sea ice and the dangers, and how they have to communicate what's safe now and what's different. And I like that you mentioned the urban, he's lucky that in the community he has a lot more connection to land than some in Iqaluit who don't have the money to go out hunting, the money to go out with elders and fishing and gasoline. And so all we know is that, connection to elders, connection to the land, is protective factors, not only for suicide prevention, but protective factors for well-being and, against TB. It's an enormous question, and I don't think I'm really answering it. But also, like something I've paid attention to, and Hannah, who's with me on the call, who's young and spent time with the youth, is, they're on TikTok and they're transmitting culture in new ways. And it's not about, the past is the past, but there's some beautiful things that are happening about transmission of culture. And I don't know if you've seen North of North, that's cultural renaissance for Inuit, this TV series. It's a comedy about mother-daughter in Iqaluit, and it does and Ida, who gave the idea of the TB sanatorium visits, she's an actor in it. So anyway, I think I'm just touching on, there's new ways to share knowledge and to be safe and to adapt. And I think we have to be open to that.
Thank you.
Thanks so much. We can come back to some of these insights afterwards. So now I'd like to introduce our second speaker, Karuna Sagili, who's currently working as an independent consultant. And she's a biomedical and public health researcher working at the intersection of global and public health research and advocacy with a focus on health system strengthening. And she will talk to us about the effects of climate change on TB and health system preparedness in India. Karuna, can you share your slides, please? Yeah.
Hello. Hi, can you see my slides?
Yeah, please go to full screen.
Okay, that's good. Good afternoon,
Yes.
everyone. Thank you for this opportunity. To ShiftTB, thank you very much for this opportunity for putting across this important session on climate change and TB and overall as a planetary health. So I'm here to present a few of the findings that I discovered for myself on the climate change and TB. This is a new area. It feels like new area, but it has been there. The thing that we did not focus on it. So let's dive into it. I don't want to take much time on telling what TB is and all, but the fact that TB is here, it's an ancient disease. It's literature goes back to like 9,000 years. There are evidence on showing it's 9,000-year-old. It's infectious and a social disease. It's just not a medical part. With an annual burden of 10 million cases every year, like if we look at over the last decade, every year we are reporting over 10 million cases and 1 million deaths. Scientific and social developments reduce the burden in Western countries. However, the burden is high in low and middle income countries. TB has several risk factors: poverty, undernutrition, migration. I think all these are well known. But what is new is the link with the climate change, which is exaggerating these risk factors, and it is going to have an effect on TB prevalence or burden overall. So let's look at it. I did this for India. I'm basically from India, and also I was looking why only I should do India, why not other country? But then India contributes 25% of the global TB burden. In 2024, it notified 2.7 million cases. And India also is the seventh most affected by climate change. apart from the burden of other risk factors, like, say, for example, diabetes. It's now called the diabetes capital of the world. It has very high levels of smoking. In 2017, 266 million adults were reported as using tobacco in some form or the other. So all this puts India at a very different space. And if there is major disruptions in Indian TB program, it's going to affect globally also. So the simple rationale was that this climate change is triggering extreme events, droughts, floods, and affecting all parts of human life, and it's affecting the TB risk factors. However, TB is not an immediate concern in most of the climate events. There is no focus globally or locally on understanding climate change impact on TB and to mitigate its consequences. Now, TB, when a flood comes, TB is not the first thing people will look at. So that's where we are lost, actually. So we did this literature review to understand where do we stand on this. I'm not going through this slide. This is on climate vulnerability and current response in India. India is quite vulnerable due to its geographical area, types of soil, biodiversity, all the other things. The work started in 2018 with a vulnerability assessment, and 2008 with a vulnerability assessment, and they are going well. They have a lot of initiatives, but the part of health and overall within the health TB is very, very, very limited. So I use the analytical framework, complex adaptive systems framework, and it had connections with the different 6 sectors, and it gave me an opportunity to build a causal loop diagrams. So this is the framework that I used. Of the six areas, ecological services, which includes all the environmental, the ecosystem aspects like temperature, air pollution, poverty, migration, each one of them, there was evidence which showed that increase in these factors is attributed to climate change. And these are already known risk factors for TB. For example, temperature is, TB is a seasonal disease. In winter, there are less number of cases. In summer, there are more. Is it just a seasonal, or is it something to do with climate? So there was one study which showed that when there is an increase in 1 degree centigrade of temperature, there were more cases being reported. So this is an area which we need to explore further. Previous literature has showed that we spoke more about seasonality, but we did not connect it much into the climate change aspect. Risk factors like poverty, migration, food insecurity, which Carol also mentioned in her talk, these are directly affected by the events that are happening due to climate change. I will dwell a little bit more on the next one. So when I see these extreme events in India, the last over a decade, there were severe heat waves, droughts, and extreme floods in Bihar, Chennai, Mumbai, Assam, Kerala, and West Bengal. What did they do? They created a lot of displacement. Heat waves created a lot of droughts, because of which there is a lot of migration, and floods created damage to the crops, which contributed to reduce in food production, and the disruptions to the health systems. So they have multiple effects. This, I'm not sure how clear it is, but this is a causal loop diagram. I try to make it showing that how climate change increases these different events. And yeah, if you can see the droughts, how they reduce the water availability. When the water availability is less, food production is less, and it increases food insecurity, which increases malnutrition, and malnutrition is a very well-known risk factor for TB. So these This is how this whole thing is built. But when I build this, then I realize the impact of climate change doesn't stop at one of these things. It affects different cascade of TB, different aspects of TB, whether it is migration or whether it is mental health, when all these aspects are affected by climate. Infectious diseases. There is documented evidence that HIV is increased during climatic events, due to migration, and as there is more cases of HIV, and and people are in migration in camps, in refugee camps, or any other places, there is less access to health services, which also is causing more TB cases. So that is one link. So everything we need to look at in detail, how and where TB is coming. So TB is not alone, or it is not invisible, but we need to wear that lens to see that. So coming to the health system focus, how health systems are disrupted. Here, I'll mainly take the example of one of the couple of papers that we could find. First of all, there are very limited literature which document these disruptions. From India, I found very few. I borrowed one or two from the outside, like there's a paper from Philippines. So what they did was infrastructure damage. There were several microscopy centers. There were several diagnostic centers that were damaged. The peripheral health centers that were damaged, and the patient records were lost. Drugs in 17 centers. This is from Kerala. In Kerala, there was a severe flood in 2018, which costed, they did an estimation of, which costed more than a billion rupees damage, and 148 patients had their treatment disrupted. They had to give extra doses. 17 centers lost their TB drugs. And the tracing was a bit easy because thanks to the Indian TB program, because they have this digital system across the country. So because of the digital data, it was easy for them to locate people. But a similar situation when it happened in Philippines. Philippines didn't have the digital system at that time. This was in 2013. And they struggled to find people. TB patients who were already on treatment, they could not find them. It took at least 2 months for them to find and put them back on treatment. They had digital documentation only for multi-drug resistant cases and not for all TB records. Adaptations. So when climate change happens, when disaster happens, there are adaptations. So people rapidly act. Now, these are adaptations that we do at the moment. These are not planned earlier. They don't have, okay, what happens? The preparedness is not really well planned, detailed planned, but what could they do? So they used the extra drugs as a buffer drugs, which were kept to replace the drugs which are damaged. Now, these were not in the planned for a climatic event, but they were like the routine buffer thing. The replaced diagnostic equipments, used health workers relationship. This was in the case of Philippines, where they had a good working relationship with the health workers. So they tried to identify, go to different villages and recognize the people and bring them back. And the assessments for NCTs.
You're at
Yeah,
time limit.
Thanks.
So you need to really
Yeah.
wrap up.
Assessment of NCDs was also done. NCDs are also important. Now, when I looked at the health system preparedness, it was a little difficult because not all documents are available. And the disaster management plan, which had various health initiatives, but it doesn't include TB as such. The National TB Strategic Plan that the national program has at the moment doesn't have the climate change aspects included in it. brief. The disaster management guidance was also very brief, which means a lot of states are left to make their own plans. They have to come up. So this sometimes creates a gap in the services and the proper documentation of TB disasters across the country. Okay, what happens when there were floods in Bihar or in West Bengal? How did the TB programs cope? So this kind of documentation is actually not available. This is a similar causal loop diagram I try to create. Let's skip this. So what I what I felt we need to look at is that the prevalence, the climate change is increasing TB prevalence, and it is disrupting care continuum, primarily by impacting TB risk factors and the health systems. National TB programs, especially in India, may need to focus on this aspect as it is a country with a high TB burden and vulnerable to climate change. Some of the key recommendations we thought were maybe we need to revisit the National Strategic Plan and use the lens of not just biosocial, but actually also climate change, and look at where or what are the different aspects and how we have to amend those. Climate resilient health systems framework, which the WHO has created, which is a good framework. Maybe we need to see how TB can be integrated into this if the country is already working on this aspect. Leveraging multisectoral engagement for the TB, national TB climate programs. They have district level, they have state level programs. So probably we could connect with them and start working with them. There is a possibility that we could constitute TB climate committees at different levels, but whether we do it newly or we use the existing infrastructure from the national climate programs is a good things to start with. And vulnerability assessments for each state and district levels are important for each TB program to come up with their own data so that they can implement accordingly. And research, we have a dearth of data on climate change impact on TB at the local levels. So I think we need to invest a lot in research and understand, do operational research probably to identify the gaps in each localities, districts or states, and move forward with that. So this is very few insights. It's very brief, but there is a lot more we have to discuss about this. At least I would suggest that we start with deliberations and discussions on this aspect of climate change and TB. Thank you very much.
Thank you very much, Karuna. I can take one question. The room is very quiet today. Who would like to ask a question or has a comment for Karuna? Carol, yes, please go ahead.
Okay, just thank you so much, Karuna. I really appreciated your presentation, and I'm wondering, are you seeing more kind of interdisciplinary collaboration in India at the governmental level? Like, is the health department talking to the, meteorological or whatever? Like, are you seeing more of that? Is it giving you hope?
Yeah, in India, the program has been doing this multisectoral approach quite a lot. Like they started collaborating with several departments. They have something we called as arrangements between the two, like an MOU, and we call it Memorandum of Understanding, with the railway department, with military, with different sectors. So they are quite fast, moving fast on these aspects. However, I didn't find much with the climate part. So the thing is, this is since WHO launched the guideline only recently, so this is an area which we should start, and they can use the existing infrastructure, the existing plans they have to add, or that's why I use the word amend into climate change aspect, because we may think it's not much, but over the time we might be doing all kinds of interventions, but climate change would keep on adding cases to it, you see.
Okay, thanks so much. We need to move to our next and last speaker in the interest of time. And then can I ask you to already fiddle with the slides while I introduce it? So Ellen Mitchell is a public health fellow at the Institute of Tropical Medicine in Antwerp, with a background in social sciences and also with an extensive background in working in the TB space among epidemiologists the last 10 years also at KNCV. And Ellen has been a member of SHIFTB, I think, since day one. So we're really happy to have her here today. Her work has covered quite a few areas in relation to TB. She's worked on TB stigma, active case finding, TB mortality measurements, gender, and has a knack for rethinking taken for granted aspects in TB. So Ellen, the floor is all yours. She will talk to us about co-designing tools to filter air.
Thank you, Nora. Thank you for the invitation to share a little bit about our adventure on World TB Day. It's definitely a privilege to have your ear for 8 minutes. And in the spirit of co-design, I'm also asking for your help with this work. So I hope in this talk just to share a little bit about my excitement about citizen science and environmental justice work in tuberculosis, and also some of my anxieties about the co-design process. Let's see, is this working? Yeah. So as the climate warms and the streets are growing too hot, people are heading inside for the comfort of air conditioning. And of course, the elites have been stuffed in their cars and their offices for a very long time. But the working classes and the poor are also heading indoors. And the consequences of this for airborne infectious disease transmission is pretty straightforward. We know that we're going to be breathing each other's air. And so what does that imply? And humans already spend 85 to 95% of their time indoors. And lots of new techniques are helping us to appreciate how alive that warming air is. And the diversity of organisms suspended in indoor air has become this sort of source of kind of creative inquiry and also anxiety for a lot of folks. And especially with catastrophic flooding, like we see now in Gaza province in Mozambique, where the air is so wet. We also see the growth of molds and fungi and aspergillus and all the co-infections that make tuberculosis post-TB disease so challenging. And many of you and our friends are pulling TB from the air using sticky masks and fancy chambers. And it's telling us so much more about how TB moves and also how does it survive. And for me, this is kind of a big question, like how does it stay? It thrives in the caseated lung. It thrives in outdoor air. It thrives in, it's hot, it's cold, it's dry, it's wet, it's hypoxic. How does that all work? And we know now, just last year, we realized that tuberculosis remains the captain of death because of the ship that it travels in, that the sputa forms these crystals that protect it and allow it, bioaerosols, to stay airborne for much longer than we thought. And so that's this understanding of the air and how it works. We're learning new stuff every day. And yet, at the same time that we're having all these breakthroughs in bioaerosols, we're sort of stuck in the mud with our traditional airborne infection prevention and control. And the public health community, I feel, hasn't really helped us very much to incorporate these new findings and has often tried to make infection control seem like some kind of rocket science or the purview of these, hygiene engineer experts. And it's been very difficult for regular people like us to make sense of it. And even during the COVID pandemic, I think you might agree that policymakers went out of their way to try and convince us not to do things that would have protected us and to do things that frankly were hygiene theater. And most damning from my perspective is how policymakers tried to shift the responsibility for breathing clean air from the state to individuals. And industries have also contributed to this confusion. So the clean air industry, as you may know, is filled with lots and lots of things on the market that don't actually work. And it uses this bait and hook methodology. So it sells you these cheap base units, and then there's an extraordinary markup on the commodities that you would need to be able to use the thing. People know this as the razor and blade business model or the bait and hook business model. It's really well established, but how it plays out is that people with the greatest indoor air quality risk are unable to acquire the technology that they would need to mitigate that risk. And again, these industry people have made it seem like indoor air quality is extraordinarily complex and that we need some kind of space technology and engineering knowledge to be a part of it. But as one Nobel laureate observed, you don't necessarily need a weatherman to know which way the wind blows. People who are armed with practical skills and common sense are showing us a way forward. And who are these people? Well, we've just seen this proliferation of citizen scientists, STEM feminists, these kind of engineer dads. That's a big thing in Canada, the engineer dad. These tinkerers, the environmental justice advocates are stepping into the breach and helping to fill this sort of trust complexity business gap. And they're individuals who are downwind of wildfires, they're individuals who are overwhelmed with floods, they're environmental justice activists, they're introvert little woodworkers in their garages. And these people are most active where the air quality is the worst. And they're developing not only air filtration techniques, but also little meters and metrics to help us understand the risk that we face. And this idea about visibilizing, making the invisible presence of tuberculosis visible, or the presence of particulates visible, has, I think, been one of the most interesting parts. So do-it-yourself portable air cleaners are an environmental justice tool that has really come to the fore. And I think many of you have seen these. You can find the designs for them on GitHub. Anybody with a laser cutter or even scissors and some duct tape can make one of these things. And it makes them very, very scalable. And our project seeks to make these also more available in healthcare settings where the risk of tuberculosis is high. And far from being sort of these homemade, kind of ugly little things, they tend to be, if you really measure it, both quieter and more cost-effective, and even sometimes more powerful than ones on the market, especially if you can overcome this issue of the consumables. And here's an entrepreneur, innovator, disruptor with a new kind of filter that's being tested in China. So the task project that I lead is designed to ask people working and being cared for in overburdened health facilities to help design new tools to clean the air. And I don't need to tell you why that's so important. And this formative research is about understanding what people want and how to make it, basically. And it turns out that what people want and how people feel about portable air cleaning is a complicated business. And here's, I think, where I'm asking for your help. So how do we ask people questions about what they need and want if we don't even have a shared lens or a shared vocabulary or a shared conception about risk in the air? So some of the things that we'll be doing, obviously the in-depth interviews and focus groups to try and bring some of these norms and the kind of political sensitivities that Carol mentioned earlier to the fore. Air, as you know, is extraordinarily political. And I think my anxiety is around how will we, given all the hierarchies in a hospital, how will we make sure that the voices of the actual users are centered in this process? So I've run out of my time. I just want to say that this project will have a tactile aspect. So we'll build and destroy and rebuild and reframe our portable air cleaners. And ultimately, we'll ask people to make some discrete choices. So we'll say, once we've got all the ideas on the table, what are your priorities? And then we'll build it. So that's what I wanted to share with you. I have some questions myself. You may also have questions. It's ridiculous to give a talk about co-design all by yourself, but I just want to share that I am part of a much larger and much more interesting group, including people from the National Tuberculosis Program, NGOs, universities, engineers, frontline workers, wonderful master's and PhD students. And we represent a whole bunch of universities in Global South and Global North and NGOs and blah, blah, blah. All right. Thank you very much.
Thank you so much, Ellen. This was fascinating. I open the floor for questions. Let's see. Amrita, please go ahead.
Great presentation, Ellen. Thank you. I think what fascinated me most about your talk and several of the other talks, it just sounds like innovations coming from all kinds of hidden spaces. Yeah, whether it's, using TikTok or to communicate, or whether it's kind of, these home dads who are just engineer dads, or your terminology. I just think that's so refreshing in TB, where it's always whatever innovation is happening, it's always in a very formal research space. It's through, we rely on this kind of traditional evidence-based kind of solutions. And I know partners such as Stop TB are, of course, kind of forging ways ahead for community action. I just love this, and I wonder if there's something that you can reflect on just in your moments of being engaged in climate change and climate kind of justice and adaptation, that you can comment on that.
Yes, well, I think like many people, I got pretty radicalized during COVID and disappointed with my heroes in the public health space. And I was looking around for people who could help me solve my problems, and delighted to find all of these, weird, not public health, no, weird is the wrong word, but like these non-traditional sources of insight and information and practical knowledge and affordable tech that I needed for me and my family, but also I knew that my friends and colleagues in the Global South needed. And to try and to interact with these folks, many of whom are based in the Global South, and their in sort of infectious enthusiasm for this, and helping to set up these kind of South-South things. I think that's been some of the most fun that we've had, and trying to figure out, okay, how are we gonna make all the math add up on this and simultaneously make it beautiful. One thing that you notice very quickly when you're building portable air cleaners is that aesthetics are so important. How people feel about a design, do they want it in their house? Do they respect it in the hospital? the aesthetics of it is so, so important. And that's something we haven't, I'm such a nerd and not very aesthetic that it took me a long time to wrap my head around that. And the co-design process is so useful for that, for people to say, no, I have to like it also. Don't bring that cardboard weird stuff into my hospital. It has to be beautiful also.
Yes. And I think, thank you so much, Ellen. I think it's really fascinating how in many of these aspects of what I think we've seen in these three presentations, social scientists can really, bring their core expertise. So how do you develop a vocabulary about air and that something might be wrong with the air or what good air is and bad air? It's probably something that people are already talking about and have their own way of managing air, right? And so finding this shared language and shared vision of what good air should be in this place is something that where social scientists can excel. We have all these participatory methods and experiences with also handling power dynamics. There's a question in the chat here from Julie Hart. Are there preferred do-it-yourself portable air cleaners that you recommend?
So the type of portable air cleaner that you need is a function of the size of the space and the occupancy of the space. So there isn't one size that works for everyone. That's the other exciting part. I am you'd have to tell me a little bit more about your space. I can tell you that there are websites where you can put in your space and people will give you designs based on your specific specs and how much you want to spend. Portable or personal computer fans like this are very inexpensive. Remember old desktop computers? We had these fans. Now, so these you can recycle them and you can string them together in a daisy chain. And they're very powerful. And because they're for computing, they're also very silent. Turns out if you make a noisy fan, no one wants it. That's another top tip.
Love this. It is inspiring and empowering is what Julie recommends. And there's another comment here in the chat that the war in Iran and the choke at the Strait of Hormuz are leading to a shortage of gas cylinders in countries like India. And this will lead to push households to use solid fuels, which again then leads to possible increase of TB as an institutional amplifier.
Right. So here's another place where portable air cleaners can pull out those particulates from wood smoke and the mold and fungi from floods. Like it's not just that they capture infectious bioaerosols, but also they capture all the other junk in the air that is that damages our lungs and makes us more susceptible to tuberculosis and inhibits our recovery. So in this sense, I like them because they're pathogen agnostic.
Very nice. So it sounds like, usually I was a bit hesitant to put the planetary health topic for this World TB Shift webinar, ShiftTB webinar. Oh my God, my words. But actually what we've heard are a lot of opportunities for fascinating new research ideas and amplifying solutions and alternative ways of tackling this, where social scientists can also play an important role. So that leaves me at least with a bit of a inspired and empowering, as one of the audiences said, feeling, for tackling this very, very highly complex and interwoven and intersecting sets of challenges. I don't know if anybody else would like to have or say a last few words. Otherwise, we're already 1 minute over the hour, but I think this was really nice.
Thank you, Nora, for excellent facilitating, and thank you so much to the speakers. Really fantastic and inspiring talks.
And we look forward to seeing more of your important work.
Thanks, everyone.
Thank you all for attending.
Thanks for the invitation. Have a good day.
You as well.
Thank you again. Thank you very much.